Okay, this might be well known for you, that if we talk about the brain, we have four supplying arteries, 2 internal carotid arteries, and 2 vertebral arteries. And the vertebral arteries, they fuse and become the basilar artery, arteria basilaris. Together we tend to call it the vertebro-basilar system. And you can see that the greater part of the blood comes through both carotids. 80% of the cerebral blood flow is supplied by the both internal carotid arteries, and the remainder comes from the vertebro-basilar system. Now, before I continue with the arterial supply of the brain, I will discuss the supply of the spinal cord, which is very important as well. Now, we have an anterior view and a posterior view of the spinal cord. And what happens is the following. You see, this and this one, these are the vertebral arteries, and from both vertebral arteries, a small arteria spinalis anterior is given off. Both anterior spinal arteries fuse and they become a single arteria spinalis anterior, which runs down across the midline on the anterior side of the spinal cord. On the dorsal aspect, you'll find an arteria spinalis posterior on each side, but they don't fuse and run down next to the midline, so we have 2 arteriae spinalis posteriores. So this means in total there are 3 longitudinal arteries running down along the spinal cord. This can never be enough for a sufficient supply of the spinal cord. Moreover, it would be a very dangerous situation, because it would mean that the complete blood supply was dependent on these tiny parts of the vertebral arteries. So we see the following. We see that on certain level there's an additional supply by so-called arteriae medullaris segmentalis. Not on each level, but on several levels, and it is really variable. You could say on anterior and posterior sides you have between 6 to, let's say, 12 additional supplying arteries left and right. Normally, one of them is larger than the others, and that one has been called arteria radicularis magna. Vascular surgeons know it pretty well. They call it the Adamkiewicz artery, and normally it's a branch of the 11th posterior intercostal artery, because when they're operating in this part of the aorta where this 11th intercostal artery originates, they take care not to compromise the supply to this artery. So in detail it looks a bit like this. So this is the spinal cord, the anterior spinal artery over here, and then 1, 2 posterior spinal arteries. This is the aorta, this is the segmental artery, in this case an intercostal artery. Here runs another one, and this gives off a spinal branch which goes inside the vertebral canal to supply vertebra, to supply dura. Of course, it supplies the roots by so-called radicular arteries, and those radicular arteries stop here, but some of them continue and they contact the longitudinal arteries. And if that happens, then this radicular artery changes its name into segmental medullary artery. And this happens on specific levels. So you need this for a sufficient supply of the spinal cord. Okay, now we go back to the brain. This is a view of the base of the brain, so it's an inferior view. And you see the 4 supplying vessels, the 2 internal carotid arteries, and this is the vertebro-basilar system. And then you can see that they connect. There are anastomosing arteries, a kind of a circle is being formed, And this was first described by Sir Thomas Willis in 1652. He was an anatomist and surgeon from England. And therefore it's called the circle of Willis, but it has an official anatomical name as well, circulus arteriosus cerebri, the arterial circle of the brain. And that's quite interesting because we have this anastomosis, it may compensate for problems. If one of the supplying artery tends to form a stenosis, there may be some compensation. And that's an important thing. So this circle of Willis may help us to prevent ischemia. Normally, the circle is complete, but we have to be aware that these posterior communicating arteries, it's called a communicating artery, may be very thin. So thin that it's very difficult to see them, for example, on radiological images. I've done a lot of research myself on these cerebral arteries, especially the innervation of the arteries, and in all the specimens of the circles, I saw complete circles. So I'm pretty sure that in most cases you will have these posterior communicating arteries. So now let's have a look. These are the supplying internal carotid arteries. This is the supplying basilar artery. And from this anastomotic circle, 6 large arteries go into the brain. It means 3 to the left and 3 to the right. So we have an arteria cerebri anterior, and here is another one. We have an arteria cerebri media, and here on the opposite side, and we have both arteriae cerebri posteriores. So 6 large arteries leave this configuration of the circle of Willis and go into the brain. You can see that in this case the middle cerebral artery is the biggest. It's kind of a continuation, and you can see that the posterior cerebral artery especially receives its blood from the basilar artery. Now let's see how these arteries continue. The anterior cerebral arteries, they run between the hemispheres. They run on the corpus callosum. And we see how a middle cerebral artery runs in the lateral direction to reach the cortex. Of course, we need branches of these arteries to enter the brain. And you can distinguish 2 kinds of branches. First, we have the so-called perforating or central branches. And they come from the first part, let's say the proximal parts of these large arteries. So this is the frontal section, this is the middle cerebral artery, and here you see from the proximal parts perforating or central branches which immediately go up inside the brain substance, and also from the anterior cerebral artery and the posterior cerebral artery you will see similar branches. And these branches, these perforating branches, they go straight up into the brain, to the deep parts of the brain. They go to the so-called basal ganglia, to the thalamus, and to the internal capsule, perhaps already known to you. So to the deep areas of the brain. But then the artery continues to reach the cortex, and on the cortex there's a very extensive network, many branches, and tiny branches of this network penetrate the cortex. So these branches running on the cortex are called cortical or superficial branches. But I found out in literature you have other names as well. Sometimes they're called leptomeningeal arteries, sometimes they're called pile arteries. Why leptomeningeal? Do you know the term leptomeningeal? Is it a well-known term to you, leptomeningeal? No, it doesn't matter. If you take the pia mater and the ergnoid mater together, these are the 2 softer membranes compared to the dura mater, and these 2 together are called the leptomeninges. So the leptomeningeal arteries are the arteries which are closely related to the leptomeninges, and we have seen in one of the first slides of my presentation that the arteries on the surface of the brain are running in the subergnoid space. So they're between arachnoid and pia mater, and therefore you may call them leptomeningeal arteries, which is quite often done in the scientific literature. We also know that branches which penetrate the cortex are already smaller than 300 microns. And many of the branches which penetrate the cortex are as small as 100 microns. This is true microcirculation. And this is a complete different way of supplying an organ than you find in most organs. You may be aware of the fact that in most organs you have a kind of a gate. When you take a lung or a kidney or a spleen or the liver, there's one gate, quite often called the hilus or hilum, where blood vessels may enter, where veins may leave. In the case of the liver, for example, the hepatic ducts containing bile will leave. In case of the kidney, the pelvis ureter will leave. But normally you have one gate. But here is completely different, because it's and then the arteries go inside the gate, inside the organ, and then divide in many branches and supply the organ from inside. This is completely opposite. There's a division, many divisions on the surface, and then we have tiny vessels supplying the cortex. But it has a reason, because this means that there is a possibility to regulate the supply to a particular cortical area precisely. And we come back to that in the final part of this lecture. So this is a view of the arteria cerebri media and the cortical branches. I have to say this is a simplification of the truth. I will show you some real pictures in a few minutes. And well, you can say this is a supplying area of the middle cerebral artery. When you reach the edge and continue into the hemisphere, it would be the supply area of the anterior cerebral artery, and this would be the supply area of the posterior cerebral artery. And seen in a medial view, when we look at the inside of the hemisphere, you see this is the arteria cerebri anterior running on the corpus callosum and supplying the inner aspect of the hemisphere. And this is the supply area of the arteria cerebri posterior. So we come to the next part about the vascular territories, because I already was trying to indicate these territories. And quite often in anatomical textbooks and atlases and also books of neurology, you find such schemes. Nice colored schemes. It says, okay, this is the area for the middle cerebral artery here on the edge, and continuing on the inside of the hemisphere, it's the area of the anterior cerebral artery, and here inferior side of the temporal lobe and occipital lobe, we have the supply area of the posterior cerebral artery. And it's useful to know these things, because it means you can predict symptoms when there's a supplying problem. If there's a stenosis or whatever in an artery, you will have ischemia and you will have problems. And well, if we talk about problems with the supply, you may, well, as an anatomist I can see it quite simple. I can say, well, you have a lack of blood, and it means you may develop an ischemic infarction, or too much blood. When blood enters the brain, it's an intracerebral hemorrhage. But we go to these sites and there are several kinds of infarction. So if you have an obstruction in a large vessel, it may happen that you have a cortical infarction. But I will show in a few minutes that there are many anastomoses between those cortical branches. So sometimes the cortex may be spared, but then you will have a subcortical infarction. When there's a problem in those small perforating vessels, which go straight up into the brain, to the deep areas of the brain, if the problem lies there, you will have a so-called lacunar infarction. This is all for neurology, it comes later. And the watershed infarction is very special. A watershed is the area where two territories meet. It's in between here, for example. It's called the watershed area. And when you have a low blood pressure, a hypotension, it means that the most peripheral areas of supply will have the severest problems. And then you may develop an infarction in this area, and therefore it's called a watershed area. Okay, but going back to infarction, if you have a problem with the supply, you may understand the symptoms if you know the supply areas of the arteries, and it's quite often suggested in the textbook that is quite constant. But I think, and then you can, for example, explain some symptoms. So what do we see here? We see the so-called homunculus, which means little man, which is lying along the motor cortex, the primary motor cortex, and you see which area of the cortex is important to supply the motor information to part of the bodies. So what happens if we have a problem, if we have a stenosis in the arteria cerebri anterior, of a large branch of it? We have seen it supplies the medial side of the hemisphere, so you will find a paresis or paralysis in the lower limb. Quite understandable. If the problem lies at the level of the middle cerebral artery, which supplies this part of the cortex, you may have problems in the upper limb. In the face, you might have the hemiparesis. Or you may have problems in Broca's area, which is very important to produce speech. And then, if the problem is in the posterior cerebral artery, it's especially the vision which may be impaired. You may have a so-called hemianopsia. And this is quite well understandable, and in many cases it's useful, and it happens that way, but not always. And I just want to illustrate that there's a lot of variability. And this was, I think, very well demonstrated by Bart van der Zwan, who is a neurosurgeon at the University Medical Center in Utrecht. And he did a PhD at the Department of Anatomy in the early 90s. And he wanted to demonstrate the variability of the vascular territories. So what he did, he took the 6 large cerebral arteries, so arteria cerebri anterior, media posterior, and then left and right, so 6 in total. And he put cannulas, 6 cannulas into the 6 arteries, and filled them with different stains under physiological conditions, physiological pressure, and he tried to mimic the physiological conditions as much as possible. And this gives some indication about the vascular territories. He didn't want to use the old brains, which enter the Department of Anatomy, because you may understand that people who donate their body to science are generally old people. We are very grateful to those people that they do it. But he wanted younger people. So what he did, early 90s, he went to Detroit in the United States. In those days, 15 murders a day were committed. So at night he could go to the pathologist with his buckets to collect the brains, and then finally, in the end of his stay there, he could say, "I've got the brains," because then he had, I think, worked about 30 brains, and he was able to demonstrate the variability. And he found really a lot of variability, but not only between the individuals, also inside the individuals. So, for example, this is a superior view of a brain. In this case, this is the anterior side and this is the posterior side. You see in this kind of blue-green, this is the territory of the anterior cerebral artery, and this is the watershed area to the red territory of the middle cerebral artery. But you can see on the contralateral side, this watershed area lies far more laterally. So really, inside one individual, you may have this variation. Also interesting thing that he noticed, what in one experiment, something went wrong with one of the cannulas. The pressure dropped, and instantaneously he found that this watershed area, this boundary, was shifting to medial or lateral. I don't remember which cannula had the problem. So that means that the anastomosis in the watershed area are really functional. And if you zoom in on the watershed area, you can see many anastomoses, and you can see how the green color meets the red color, or sometimes it has mixed a little bit. Those anastomoses between the supplying arteries are called leptomeningeal anastomosis. And this, just like the circle of Willis, is helpful for us to compensate for problems. It means if a stenosis develops slowly, very slowly, then these anastomoses may help to shift the boundaries between the territories. If you have a sudden obstruction, it won't help, of course, but in slowly developing, it may help. So our body did a few things to help us to prevent ischemia. At the level of the circle of Willis, we've seen that. I just discussed this leptomeningeal anastomosis. And finally here, there's also a direct anastomosis between a branch of the facial artery and the ophthalmic artery. And the ophthalmic artery is a branch of the internal carotid artery. To be honest, this anastomosis is the least important. It helps not so much. The other ones are more important and may help us to prevent ischemia. And this brings us to the final part of the lecture, the regulation of the cerebral blood flow, which is a difficult thing to understand, but it's very important. And I will try to present the main lines. There are so many details to know about it, and to be honest, so many things we don't know yet, but I will try to present the main line. So first, let's have a look at the physiology of the brain circulation. The cerebral blood flow is extremely high. It's 750 to 1000 milliliters a minute, which means it's 15 to 20% of the cardiac output. If you say our cardiac output is 5 liters per minute, you see 15 to 20% is going to the brain. And that's a lot, especially if you consider that the brain weight is only 2% of our body weight. So a lot of blood is going to our brain. Our neurons need it because they cannot store glucose, they need a fresh supply all the time, and they need a lot of oxygen, and they are moreover very sensitive for ischemia. So the precise regulation is necessary because we have to adapt the regulation to varying circumstances, and we all know that circumstances are not constant. For example, our blood pressure is not constant. It varies. Intracranial pressure may change. We all are aware of postural changes. If we are lying and we go up very quickly, you may be lightheaded for a few seconds, but you also know it compensates very quickly. It's a compensation mechanism. Also, the blood gases, they change, and brain metabolism is extremely important because, and this has been shown by very smart imaging studies, if, for example, I'm doing this with my fingers, I may be pretty sure that somewhere here on my primary motor cortex, a tiny cortical area which connects to my fingers and the muscles over here, is needing much more blood at this moment and is getting it. It's just happening. It's a very close coupling between the needs and the supply, between the neuronal activity and the supply. So we need regulating mechanisms, of which the first one is just general because it's just what is entering the brain. It's a function of the heart and the large vessels. You could say it's the blood pressure which arrives to the brain. But the other factors, they are related to the function of our smooth muscle cells. You may know that inside the wall of a blood vessel we have smooth muscle cells, which are circularly orientated. And when we contract those cells, you have a vasoconstriction. And when you relax those cells, you have a vasodilation. Actually, that's the way to regulate flow. And there are varying factors which are able to work on these smooth muscle cells. First, a so-called myogenic mechanism, which is an intrinsic capacity of smooth muscle cells to contract as soon as they experience stretch. So if the blood pressure rises, it means there's some stretch on these smooth muscle cells in the walls, and they automatically contract a little bit. It means the vessel wall becomes stiffer a bit. There's no passive following of pressure rise. Now the vessel reacts. That's one thing. A second thing is neuroregulation. All blood vessels, except capillaries, have an innervation. But you will be amazed, and I will show you that in the final minutes of this presentation, how many nerves you find surrounding the cerebral arteries, especially the large cerebral arteries. The cerebral arteries are very densely innervated, perhaps the most dense innervated arterial system in our body. And that means something. And also, whilst most arteries have mainly a sympathetic innervation, the brain arteries also have a parasympathetic innervation. And there's only one other, and they have a dense parasympathetic innervation. There's only one other arterial system in our body which has a dense parasympathetic innervation. And here it is again. These are the penile arteries, the arteries in the penis. Why? The parasympathetic nerves, they cause a vasodilation. You may imagine sometimes it may be useful for the penis, but for the brain it means you have a specific additional regulation mechanism. Okay, so this neuroregulation plays a role. Then we have the blood cases which play a role. The metabolic factors are very important. So if certain neurons become active, they are producing metabolites and they diffuse to the small arteries and arterioles nearby and directly act on the smooth muscle cells. They can directly relax those smooth muscle cells in order to dilate the blood vessels. Adenosine is such a substance, even potassium can do it. And then in the endothelium, many vasoactive substances are produced. I leave this out of consideration, because now I want to show how some of these factors interact. And then I have to introduce the so-called cerebral autoregulation. This means that the perfusion of our brain, just means the blood flow of our brain, is constant in the physiological range of the blood pressure. This is very important. Why? Our brain is inside the skull. It's a closed box construction. There's no possibility to expand the volume. So it would be a very bad idea if the amount of blood would increase rapidly upon an increase of pressure. So it's very important to keep the total flow constant in the physiological range, and that's what's happening. You can see this is the blood pressure and this is cerebral blood flow, and in the physiological range we have a constant cerebral blood flow. Only when the pressure is too low or too high, you will have a problem. How can this happen? So then you have to know a little bit about this formula. Maybe you have seen it before, maybe you did your best to forget it, but it doesn't matter. It means that the flow is the pressure divided by the resistance of the vessels. And what is the vascular resistance? Is this formula. Mu stands for the viscosity of the blood. Well, the viscosity doesn't change so quickly. L is the length of a vessel. It won't change so quickly. P never changes actually. R is the radius of a vessel. Yes, you can change that. So what does it mean? If the blood pressure rises and you want to maintain the flow constant, you need a rise of the resistance. It means you have to decrease the radius, and because it goes into the fourth power, it is a very powerful thing. So if the blood pressure rises, the large arteries constrict, just if you shut down the tap a little bit to prevent too much blood to go to the brain. It's a very powerful, very important mechanism. It's caused by the myogenic mechanism, so the intrinsic capacity of the smooth muscle cells, but also the nerves, especially the sympathetic innervation, plays a role in this mechanism. And when this is okay, when this happens, that's fine. Then you have a prerequisite, you have an ideal situation for fine-tuning to the cortical areas. And then you have the second part, the so-called chemical metabolic regulation. It means that there's a coupling of the neuronal activity and regional flow, and caused by diffusion of metabolites, as if I just explained. So that's how you can see it in the main lines, and it means that different parts of the cerebrovascular tree have different functions. So in the circle of Willis, a redistribution of flow can take place as a compensation for occlusions. In the larger arteries, there is this reaction of pressure changes, which we call autoregulation. And finally, in the smaller arteries, there is a true reaction on local metabolic needs, and we call it chemical metabolic regulation. And because this is happening all the time, it means that the total amount of flow to the brain is pretty constant, and then the smaller arteries can regulate on the smaller level. So in my life I did a lot of research on especially the innervation of the cerebral arteries, and it's nice to have a few pictures in the end to give you an impression of what it actually is, because not so many people are really aware of the vascular innervation. This looks very nice as a picture on the wall, but what we're seeing here is the circle of Willis of a rat, actually, as lying on the skull base. So we have removed the skull cap, we have dissected off the brain, and here is the circle of Willis. Well, it doesn't really look like a circle, we still call it the circle of Willis. And there's some light underneath the skull base, and then you can see that these arteries are rather dark. If we zoom a little bit into this area, this is the internal carotid, which divides into the anterior cerebral artery and the middle cerebral artery. You can see all nerves around this artery. It's quite dense. There are many, many nerves. This is maybe even better to see. This is immunohistochemical staining of the anterior cerebral artery of a rat. Well, we did a specific experiment. It's not important to elaborate on that at this moment, which you can see how dense this innervation is. But this is in red. And this drawing shows that the nerves are really confined to the adventitia. So this is the tunica media, this is the adventitia. And we can distinguish two kinds of plexuses. First, we have on the outsides of the vessel large nerves, which are running in a longitudinal direction and going to the more distal parts of the vessels. And from there, tiny nerves enter the adventitia, they form a so-called superficial plexus, and finally they will reach the adventitial medial border, and there they form a circumferentially orientated deep plexus, which is a terminal plexus, because from there the innervation of the smooth muscle cells can take place. It only can happen here because the smooth muscle cells are in the media. How about the human situation? Well, I always say sitting on the front row is always rewarding, and if you are using this, you get so many good answers. You may see depth. Is that true? You may see that this is the middle cerebral artery in human, and this is a large paravascular nerve which runs outside the adventitia. This is the superficial plexus, which lies superficially in the adventitia, and these are the tiny axons of the deep plexus. They are running close to the media at the adventitial medial border. And of course I cannot wait, I wish I could wait until each of you had seen it, but you can just take this picture along with it to pass through for people who, it's the same picture, so it should work all right. Together with the glasses. You should, red should be on the left eye, otherwise, no. Yeah. Okay, this is a very interesting phenomenon as well, because we found the densest innervation in the posterior communicating artery, and maybe you remember from the drawing of the circle of Willis, is the artery which connects the internal carotid artery system to the vertebral basilar system. And that is quite funny, because this artery, posterior communicating artery, is very tiny, it's very small. And have a look, what an enormous bundles of nerves at the adventitial medial borders. You see these small parts which are lighter, they may relate to the so-called varicosities. Varicosities are widenings of the terminal plexus where the neurotransmitter is stored and is released. And after release, only the outermost layer of the smooth muscle cells will be supplied, but it's the gap junctions between the smooth muscle cells which transfers the signal into the deeper layers of the tunica media. And in the end, the complete tunica media will be the effector. Okay, just to give an impression. So, I'm getting to the end of my lecture, and this was a lot of information, various kinds of information. If I may put forward a few conclusions. First, we have seen that the meninges and the blood vessels have a very close topographical relationship, and we have transferred this concept to certain pathological conditions like the epidural hematoma, subdural hematoma, and the subarachnoid bleeding. The venous drainage goes through sinuses, but also I showed you the IVVP, which is very extensive, surrounding the spinal cord. I think an important message is that the arterial system surrounding the brain has many collaterals, and there is a variability in the territories of supply. I think that is a message which I will give to you. And finally, we have seen that the cerebral blood flow is regulated very accurately, and that it's complex. Many mechanisms were involved. I just wanted to show you the main lines. Okay, I hope this was helpful and useful, and I thank you very much for your attention.